active KNV were already on topical steroid. Next one, please. I want to walk through a few cases to show you the photos and then summarize the finding from the study. So this is a gentleman who has a history of penetrating keratoplasty, was done for hepatic neurotrophic keratitis. I believe this is his second graft already, where he developed very active NV in this area that led to also a central haze in the cornea. His vision came down to count fingers at 3 feet, and then was started on the treatment. We can notice in figure B over here, just in a few weeks after treatment, the central haze resolved quite nicely. NV started to regress as well. Patient altogether had about 6 months of treatment. And the last follow-up shown in figure C, this is a patient just over a decade since the initiation of the treatment. His vision remained at 20/25, and the central cornea is very clear. The NV remained in the peripheral area, but did not progress after the discontinuation of the bevacizumab treatment. Next one, please. This is a patient who has a soft contact lens related corneal ulcer that was treated with antibiotics and resolved, the ulcer resolved. The patient subsequently developed corneal haze, as well as some limbo stem cell deficiency. You can appreciate that the NV is very active, and we see this almost C-fan shaped NV come to the center of the eye. This is quite classic for active angiogenesis in the cornea. So patient was started on the treatment. Similarly, in a few months, the central NV, the active NV regressed, and the haze also went away. So vision improved from 2400 to 2050 in a few months. And then patient similarly was treated for 6 months. At the last follow-up, which was 7 years since the treatment, vision remained quite clear at 2030. And you can appreciate in the central cornea, there was not much NV, and then the clarity is quite good compared to baseline. Next case. This is a rather atypical presentation of a Stevens-Johnson as well as atypical pemphigoid patient. You can appreciate over here this very active, again, that C-fan shaped NV coming to the center of the eye, bringing some local edema as well as haze with it and start to impede with vision. So at that time, the patient was 20/40 and started on the treatment. This again responded very nicely to the bevacizumab treatment. And at the last follow-up, this is 9 years since the treatment, vision remained clear at 20/20, and the central cornea, we can appreciate it's quite clear. The peripheral NV just remained in the peripheral area. So not all stories are happy stories. This is one of the patients that actually didn't respond to treatment that well. So this is a woman with a history of Stevens-Johnson syndrome since childhood. Just fresh off the bat, looking at this picture, we can tell the NV is not as active, as angry as the earlier cases. This is actually more chronic and also has a central haze in that area. This patient heard about the study that Dr. Debbie Jacobs was doing at that time and decided to give it a try. So she joined the study, started using bevacizumab in the device. A few months later, she had some improvement in her NV, and the haze was not as dense. Vision improved slightly. But for her, it's more the subjective improvement that she noticed. Her photophobia has gotten much better. And she also noticed that there's less debris built up in the device, I guess the midday fogging phenomenon, to the point where she really would like to stay on the treatment. She worked with various corneal specialists, actually used this regimen for over the course of 10 years intermittently. So, but she tolerated the procedure or the treatment very well without any side effects. But unfortunately, at the end of 10 years, when she eventually was stopped, the bevacizumab treatment was stopped, we can appreciate in figure C, the NV actually progressed. And then there's more diffuse central haze, and her vision also came down as well. So most of the patients responded well, but not all of them. So to summarize on the treatment, most of those patients had treatment for about 6 months. First 3 months, twice a day, usually taper down to once a day for the second 3 months. And then out of the 13 patients, 12 of them had really nice corneal neovascularization regression with the treatment. And also 10 out of 13 patients had a significant improvement in their vision. And then there's one patient I mentioned earlier, after stopping the treatment, her NV actually progressed and then had decrease in vision. All of those patients were followed by a median duration of 5 years. So overall, we have pretty long-term follow-up in this cohort. And very nice to know that for all of those patients, there's no local or systemic complication. I want to mention we had a young gentleman who has familial dysautonomia, which is known to cause cardiovascular conditions. And every time he would check in, Dr. Debbie Jacobs would check his blood pressure and also, talk to his PCP. And then he had no, change in blood pressure or any systemic complication either. So this is just graph showing at baseline, the vision is by logMAR about -1 or 2200 level. With treatment, the cohort improved and lost follow-up to the 0.6 level, which roughly corresponds to 2080 level. So majority of patients had some improvement in vision. So to summarize this part of the talk, we think the topical bevacizumab used in scleral lenses is very effective in treating corneal neovascularization as well as improving vision. We did have long-term follow-up in this study and show that there's a durable response in the majority of patients, and also show that there's very, no complication in this. So with that, I want to switch gear a little bit and talk about the use of scleral lenses in a patient of mine after corneal surgery. I think this is a nice segue to, later on we can have a discussion about how soon to have those patients use scleral lenses and what do we, watch out for in those patients. So this is a patient of mine, 51-year-old, very severe atopic disease, leading to partial limbal stem cell deficiency, also has keratoconus and had high drops in each eye. So prior to presentation to me, he's been wearing PROSE lens over about 10 years with relatively stable vision. However, he's kind of negligent in his care for his eyes and not following up very well. So this is now 4 years ago. He actually had high drops, in his left eye again. Didn't do anything, sat on it. And a few weeks later, the eye was not getting better. And that's why he came to our emergency room. This is how he presented. You can see right away the eyelids look horrible, very bad atopic disease, very thickened eyelids. And then hopefully showing up a little better for the Zoom audience that there's actually a neovascularization and then loss of the limbo landmark in this eye. Looking at the central cornea, we have a large epithelial defect, and there's also a dense metacell forming in the center. You can see the tissue is really thinning out, and then some new, early infiltrates building in the cornea as well. Overall, kind of a challenging case that we treated with fortified antibiotics and various regimens. Can you go to the next slide, please? That over the next 4 months, the cornea eventually healed. Now, this is his eye 4 months later. Healed with central opacity, and we can see the NV over here too. There's actually diffuse NV almost 360 due to the partial limbal stem cell deficiency. If we look at the slit beam over here, the iris is actually stuck to the cornea. This indicates he actually had a prior perforation before his presentation and then sealed on its own. Next click. So what's the plan for visual rehabilitation for this patient? That was actually his better seeing eye. The other eye is even worse. So we still, to get rid of the corneal opacification, we'll have to do transplantation. This is a case between either traditional penetrating keratoplasty versus a K-Pro. The main concern for the PKP will be, it's going to be a very high-risk case for rejection and failure. Because his atopic disease is very severe, those lids look horrible. With the new graft in place, it will constantly rub on the new transplant and leading to, persistent epithelial defect. The cornea is highly vascularized. That puts the cornea at higher risk of failure and rejection as well. So with that in mind, we decided to do a relatively small corneal transplant to get away from the highly vascularized limbo area. And then we, took the cataract out of, during the corneal transplant as well. Before the surgery, we actually had a very active discussion with my colleagues at Boston site. And we decided to have the patients try to start wearing PROSE lens shortly after penetrating keratoplasty to help the surface of the graft to re-epithelialize, also protect the cornea from those horrible eyelids. And that's indeed what we did for this patient. So roughly about 10 days after PK, this is after I've seen the patient twice already, making sure the PK is in a safe place. It's tectonically very stable. That the patient went to Boston site, was fitted, and started wearing a non-prescription PROSE device. And then this truly helped the surface re-epithelialize. In a matter of a few weeks, the epithelial defect healed over, and patient at 1 month after surgery was actually able to achieve 20/60 vision. Patient, of course, was very happy going from hand motion to 20/60. Next click. But this is not the end of the saga for this patient. 4 months after surgery, he started developing a suture-related infiltrate here inferiorly. This was actually picked up by my colleague at Boston site when he went in for a regular PROSE follow-up. was sent in immediately to Mass and Ear, where we did culture, and the culture grew a fluoroquinolone resistant but vancomycin sensitive Staph aureus. At this point, we stopped the PROSE treatment, and then we started patient on the fortified vancomycin. This is a fairly high concentration. It's fortified, preservative-free one, 25 milligram per ml. Next click. With this fortified vancomycin treatment, the infiltrate responded very nicely. The infection resolved. The patient continued to have persistent epithelial defect in this area and even some thinning that we can appreciate. So here is where we felt that maybe resuming the PROSE will help protect the surface of the eye again. But at the same time, we have to be aware that there's maybe still some infiltrate infection going on. So that's when we made the decision to have the patient apply the vancomycin eye drop in the reservoir twice a day, similar to the fashion that I described for the bevacizumab, in addition to his regular treatment on the eyeball. So eventually, over several weeks, the persistent epithelial defect healed. This area, you can appreciate there's some opacification and vessel coming in as well. But fortunately, his central cornea remained quite clear, and his vision came back to 20/60 level. Altogether, the vancomycin into the device treatment, we had him on for almost 7 months, and he tolerated very well, had no really complication from that. Currently, the patient's vision remains stable at 20/50 with PROSE device and pinhole to 20/25. This is a patient who was literally blind, out of a job, now, taking his life back and, leading a really successful business. So I feel like for this case, it does show that we made quite a difference in the patient's quality of life. So to summarize this part of the talk, I think the scleral lenses can be used shortly after corneal transplantation to facilitate epithelialization, especially if we know going in there's some partial limbal stem cell deficiency already. Scleral lenses can be used to deliver topical antibiotics the same way that we did for bevacizumab. Here, we're actually showing a fairly high concentration of fortified vancomycin can be safely used, at least in this one patient. And if you can click one more time. I think the take-home message, the really important part, is a very close collaboration between the corneal surgeons as well as the contact lens expertise to work together hand in hand, constant communication to care for those really complex cases. For this last patient I presented, Dr. Dan Brox at Boston site and I have each other's cell phone number. We chatted a few times before the case. We literally had the patient see me one day, make sure the cornea is stable, see him the next day, and come back see me again the following day to make sure nothing is leaking, we're not rupturing sutures. So I think that's the key over here, managing those really complex cases. So with that, I'd like to acknowledge Dr. Debbie Jacobs, who helped me with the first part of the study, and my colleagues at Boston site, and all of you. Thank you for your attention.
Thank you, Dr. Yin. I really value your expertise and your contribution to this meeting. Next up is Dr. John Gelles, and he is the director of the Contact Lens Division of the Cornea and Laser Institute and part of Hirsch Vision Group. And he's going to present long-term scleral lens wear with some interesting findings.
Yeah, sure. Thank you. All right. All right, guys. So thank you so much for having me, and thank you to the sponsors for allowing this to happen. Gia, spectacular. This is hopefully going to follow up with that very nicely. We want to talk a little bit about long-term outcomes with scleral lens wear. Quickly. Some disclosures, but some acknowledgments that have to go to Dr. Hirsch, Dr. Chu, Dr. Greenstein, and my research fellow, Dan Chung. So when we talk about, sorry, the next slide. Yeah, sorry. Thank you. So for PED management, we all know about using scleral lenses for healing persistent epithelial defects. This has been so well documented. In 2014, there was a standardized protocol that came out from Saralski and her group at Cornell. When we look at this, essentially, we're looking at 24-hour wear with a little bit of moxifloxacin in the back of the bowl with a brief removal daily for disinfection. Now, beyond that, we start to look at neurotrophic corneal ulcers and their contribution to some of the persistent epithelial defects. that are presented, and we look at the various different stagings of those. When we start to get to the severe stagings of that, we start to get severe ulcerations of corneas, and the most severe of that can lead to perforation, but we can also get desmetacial formation. When we look for scleral lens management of this, we find only one case in the literature of this, which is actually Gloria's work coming from USC. And this was in a patient who had GVHD and the formation of the desmetacial, and she showed stabilization of the desmetacial over the course of a year in the publication. I believe that she has 4 or 5 years at this point on that patient as well. 5, yes. So, so that prompted us to go ahead and actually publish our case. So this is a patient who showed up at our practice after having an emergency surgery for an AV rupture, AV malformation rupture, which resulted in a 5-7 palsy. So this individual had undergone a couple of different treatments that had failed, full tarsorrhaphies and a gold weight being placed. When they showed up, they had this very large central desmetacial. What we went ahead and did was we initiated, well, first we debated back and forth about a therapeutic penetrating keratoplasty for this individual, but decided that based on the lack of sensitivity in the cornea, that the chances for survival of that graft were going to be pretty low. What we went ahead and did for this individual was then go ahead and fit them into a scleral lens using that similar protocol with moxifloxacin into the back of the bowl. We did 12 by. What we ended up with for this individual was closure of this defect, but you can see the massive amount of bullae that are forming in the area of the so yep, I think we're good. Yeah, don't worry. All right, we'll give it another go here. Yeah, well,
Lucky number 3.
Yeah, exactly. Yeah.
Sorry, Zoomies, we're having mic problems.
All good, all good. So essentially, you know, we have these bullae formation. What we end up doing is switching to daily wear for this individual. Add some loteprednol as well as Mira 128, Mira ointment at nighttime for this individual, and just a tape tarsorrhaphy throughout the night. And then over a period of time, that starts to clear up. And then at the 1-year mark, this is what we ended up with, which was actually quite interesting because you can see that central bulking, which is likely partially or completely epithelial. But you can see that on the OCT, there's actually something that looks representative of an epithelial layer over the center of that opacity that's formed there. And if we pull up the next portion of this, you can see it took 24 days for this to actually close. And then if we look at the bullae formation, that lasted for almost a additional 30 days in that area. So when we look at this, this individual went through a very long-term rehabilitation for this. If we go ahead and move to our next case, well documented in the literature, well, I would say somewhat documented in the literature, Karen and Debbie again. And I was going to use Gia's cases of this with the anti-VEGF, but essentially what we're looking at is the formation, or rather the resolution of opacities in corneas. There was a 4-case series that was published on this, showing this is the Cressy article at the bottom there, showing resolution of these opacities over time. But when we look at this specific case with active neovascularization and lipid deposition within the cornea, we can see that this individual cleared with no adjunctive therapy. So we had a patient with KC RGP wear who also had mixed ocular surface disease, ended up with a formation of lipid keratopathy and central corneal neovascularization. Scleral lens wear was initiated with short-term management of the ocular surface disease with topical interventions as well as oral. So 2 weeks of cyclosporin, oral doxy, and Tobradex, which were eliminated by 4 weeks. And over the course of a period of time, you can see the resolution here. Once we get to the 3-year mark, you can see the near complete resolution there. And if we pull this up, we objectively measured the gradient of the opacity there, which is the grayscale units that you see there. And that individual proceeded to reduce down to about 70%, so about a 30% decrease in the density of that at its maximum densitometry. So that's pretty decent. So we'll go from there.
Thank you, John. Next up is Tom Arnold, and he has been a private practitioner, recently retired in Sugar Land, Texas. And I think everybody in this room does know Tom, so he doesn't need an introduction. Here you go.
Well, thank you very much, Lynette. And again, thanks to the sponsors, and thank you to Dr. Bergmanson for inviting me. As Lynette said, I am a clinical person, not a researcher. So I'm very humbled, especially to be in front of my ocular anatomy professor from many years ago. And also a shout out to a lot of you in the audience who I do know, and a lot of you are my mentors, and I want to thank you as well. So that being said, Stephen Vincent reached out to me a couple of years ago wanting to do a study on corneal edema after scleral lens wear in patients who have had RK. And asked if I could provide some patients. So we published in Eye and Contact Lenses just about a year ago, March 2021. And so the purpose of the study was just that, to quantify the magnitude and the regional variation in scleral lens induced corneal edema in comparing to a group of healthy eyes that Stephen had previously published regarding in Australia. He's at Stephen Vincent, most of you know, he's at Queensland Technological University. So in our office, we measured the corneal thickness across the central 6 millimeters of the cornea using a Scheimpflug device, and before and after wearing scleral lenses in 9 eyes, 5 patients and 9 eyes, and comparing them to this cohort of 15 healthy patients, young patients in Australia. The mean age of my patients was 63 years of age with a variation of 11 years compared again to 15 healthy controls. We decided to only measure the central 6 millimeters of the cornea, so eliminate any loss of data that would occur because of the upper lid. Also, we were concerned about upper lid maybe inducing some edema as well. So the variations in corneal edema were examined as a function of distance from the central cornea. We measured it in 0.5 millimeter increments, these annuli, starting in the central part and then moving out. Okay, and that is the first graph, and that's what we measured. Okay, the results were that in the central corneal edema was greater in the post-RK population by 2.19%, plus or minus 0.78%, compared to our control group, which only had 0.87% edema. And the edema increased in magnitude and variation as we got out from the center. And so what you see here in the graphical picture on the right is emerged both left and right eyes into one graft. And you see here that the central part had very little swelling. And then as you moved out to 2.5, 3 millimeters, you see a lot more. And then in the periphery, as you get out 3 millimeters to the side, you see a lot of swelling. So that's 2 eyes merged together into one graft. And then the bottom graft, I think, is very interesting because it shows that in that central 0.5 millimeter region, you see very little swelling, about 2%, which is consistent with swelling in normals. And that was in the control group as well. And then as you got out, 1.5 to 3 millimeter, 1.5 each side, 3 millimeters, then you see more. And then as you get out into your 6 millimeter zone, you see a lot. And you see the nasal, superior, temporal, and so forth in the degrees. So the edema correlated with the location of the incisions, with the depth of the incisions. The farther out you get, the more edema you have. And so the study patients were, my patients were fit in lenses with an overall diameter of 15.6 or 16 millimeters. The center thickness ranged from 240 microns to 440. Of course, some of these people are hyperopic, of course, post-RK, so that'd be a little bit thicker lens. The decay of the lenses was ranged from 141 to 180. In contrast, the control group, they were all fit with 16.5 millimeter lenses, center thickness of 300 microns, and the decay of 100. So my patients in the study, 4 of them were neophyte wearers who had never worn sclerals before. 1 was a previous scleral lens, but we washed him out with 5 days of no lens wear before he measured. The patients in the study, my patients, were successful wearing the lenses an average of 9.5 hours a day. And the mean duration that I followed them was 8.5 months. Yeah. And so, yeah, thank you, Maria. So yeah, this is our age group, 64. The number of incisions averaged 8. You can see some variation there. The fluid reservoir thickness, I tried to fit them well based on some of my mentors here today, not having a lot of excessive clearance in order to maximize the oxygen transmission. So my average is about 211, and the change in corneal thickness was 219. So this is my group. The study group, the control group, wore their lenses for 8 hours a day, and their fluid reservoir thickness averaged about 353 microns. So again, so the conclusion was, compared to young healthy eyes, that the scleral lens did induce more edema in the RK eyes. And I mean, this is probably comes as no surprise. Stephen, in our bibliography, recognized an article or referenced an article from 1987 in ophthalmology, where the practitioners were following post-RK patients fitting with low decay soft lenses. And they found naturally, as most of us have seen, a lot of neovascularization that followed those incisions, making us think that hypoxia has some, effect there in a post-RK eye. So, I guess the limitations of the study, you could say, well, they weren't age match, because there's no young people that are having RK. So of course this population was older than a younger population. And the other thing you'd say is, well, older people, present company excluded, of course, has less endothelial cell function than the younger group. However, because the individual patient had the same endothelial cells, across the back of the eye, the morphology of their cells couldn't account for more edema in the periphery than the center. So anyway, honored to be included in this, honored to be here today, and thank you very much.
And last but not least, we have Dr. Muriel Shornack, who's going to be joining us with Zoom very soon. And she is on staff at the Mayo Clinic. And she is also one of the, she's a prominent researcher, and many of her publications have included ocular surface disease with scleral lenses, as well as she's a founding member of those that do the scope studies. So as soon as we can get her up, she will share her slides.
Okay. Yes.
Is she there?
Yep, you're the host now, Muriel.
I am here.
Okay.
Okay, I'm going to hit share. And do we have it?
We sure do.
All right. Well, thank you very much for including me. Very interesting. I think I might need to talk to Dr. Jin afterwards, because I had a clinical question about potentially using a different agent in the bowl of a scleral lens in order to heal an ulcer. So I'll hold that question for later. I'm going to review just a little bit of our scope data on the use of scleral lenses in ocular surface disease. So some of you have probably seen this already, but we're going to try to answer 3 main questions here. This is survey research. This isn't clinical case reports or anything like that, but it just gives us an idea of what ocular surface conditions are currently being treated with scleral lenses, approximately what percentage of scleral lenses prescribed are used to treat ocular surface disease, And approximately where do people think that we might want to place scleral lenses within ocular surface disease management? So question number one, what ocular surface conditions are being treated with scleral lenses? In our 2015 scope study, we asked participants to indicate whether or not they had ever fit a scleral lens for any of the conditions listed here. And 43% out of 672 respondents said that they had fit lenses for keratoconjunctivitis sicca, undifferentiated. 42% had fit lenses for exposure keratopathy. Sjogren's syndrome was up there. Chronic graft versus host disease related Sicca syndrome was also about in a third of practitioners. About 1 in 5 of the respondents to the survey had fit patients with Stevens-Johnson syndrome. Limbal stem cell deficiency was another indication, as was cicatrizing conjunctivitis. So we followed that up with a survey in 2017 that had a little bit of a different design. We asked practitioners to describe a single scleral lens patient to us. And we ended up with about 290 responses. And out of those, 24 patients were wearing scleral lenses for the management of ocular surface disease. And here you see that over half of the patients in this cohort were wearing lenses for undifferentiated keratoconjunctivitis sicca, which is relatively consistent with the 43-44% in the previous study. Graft versus host disease turned out to be a little bit more commonly prescribed for than we thought it would. Exposure keratopathy was another common indication. And then chemical injury, limbal stem cell deficiency, neurotrophic keratopathy, neuropathic pain, which Dr. John certainly knows a lot about. Radiation keratopathy, recurrent corneal erosion, and Sjogren's syndrome were represented in one patient each. So a wide variety of ocular surface conditions can be treated with scleral lenses according to those studies. We also took a look at primary indications for scleral lens wear. So in 2015, we had a total of 672 respondents. Of those, 74% were fitting, they estimated that they'd fit approximately 74% of their patients for scleral lenses for management of corneal irregularity, 16% for ocular surface disease, and 10% for refractive error. When we repeated that study in 2020, we got 717 responses. Very similar. We still have a vast majority of lenses being fit for corneal irregularity, with lesser numbers being fit for refractive error and ocular surface disease. So it turns out that keratoconus is in fact the most common indication for scleral lens wear. The other question that we wanted to ask is, where do you introduce scleral lenses in your management strategy for ocular surface disease? And we realize that this question is flawed because one might approach keratoconjunctivitis sicca very differently than one might approach exposure keratopathy or neurotrophic keratopathy. But it gives us some idea as to practitioners' thought patterns when it comes to placing scleral lenses within a regimen. Over-the-counter lubricant drops, not surprisingly, were the most commonly recommended as number one therapy. Scleral lenses tended to fit between topical therapy and more aggressive therapies such as a tarsorrhaphy, amniotic membrane, graft utilization, or conjunctival flap surgery. So it looks like we're trying the simple stuff first, and if that doesn't work, we're going to scleral lenses. Now, one possible question for discussion here would be whether or not that is the correct approach. Approximately 50% of the patients that we fit here at Mayo with scleral lenses are fit for ocular surface disease. And I'm always struck by the fact that a number of these patients will come to us after they have already scarred and developed considerable neovascularization. due to ocular surface disease. And might be an interesting question to pose to the group as to whether or not we think that's appropriate, or should we be perhaps intervening a little bit more aggressively with scleral lenses in some of those patients with disease that is likely to result in scarring or neovascularization if left untreated. And with that, I will close and we'll open for questions.
Thank you, Dr. Shornack. And at this time, we will welcome any questions from the audience. Anybody right now? Okay, I see from the hot table over there, we can just pass the mic around. I don't know who got it first, but Greg.
Actually, I have two questions. One for Dr. Yin. Do you think that there's the potential for graft dehiscence if you're fitting a scleral lens early out, like a month out in that process?
Yeah, for sure. That was one of the major concerns we had for this patient I presented. That's why I think a really close collaboration between the optometrist and the corneal surgeon is critical. For this particular patient, like I mentioned, I saw the patient at least 2, I think maybe 3 times before I sent the patient to Boston site to make sure the graft looks absolutely stable. Dr. Dan Brox did the fitting, and then, you know, he's cornea trained. He made sure the graft looks good. And then I saw the patient immediately the next day to make sure there's no leakage. But I understand 100%. We had serious concern about this patient. At that time, our choice was between doing what we did versus doing a type 1 K-Pro. And then weighing the benefits and risks of each, that's when we proceeded with this patient. With the success of this patient, I subsequently had a couple more patients where I did similar fashion, maybe not as early as this one, but roughly about that 1 month window that we send patient back for fitting. So far, we haven't seen any dehiscence and leakage, but I wouldn't be surprised if it does happen. I think communication, and then for the corneal surgeon to be ready to resuture the graft if that does happen is also critical.
It may not be a bad idea to consider using a fenestrated lens for patients like this.
Yeah, just a quick question. Are you using any different keratoplasty techniques, such as like a femto enhance, so that you can get more of an overlay between the graft and the host?
Yeah,
any difference in the suturing that you're using?
So I think that's a really good question. So for MS near, I don't have access to the femto, or maybe my mic is working. Yeah, I'm actually, we don't have the femtosecond laser ready for our penetrating keratoplasty, which is a pity. I don't actually vary my surgical techniques that much for those PKs. I do absolutely for every graft make sure I have enough sutures in and they're watertight. Sometime in the clinic, if I know the patient is going back for a PROSE fitting soon, I actually do a little digital pressure on the eye to just kind of provoke the eye, see if I see any leakage, to make sure this is absolutely stable before I send the patient back.
Yeah, we've done a couple cases like yours as well and had reasonable outcomes with it. So it's been consistent. But
yeah, I think the key is really patient selection. So the several patients I've done, they've all been wearing PROSE lens for many years prior to the penetrating keratoplasty, so they know what they're doing. They had extensive training before, and then, like I mentioned, a close, monitoring between the optometrist and the corneal surgeon is critical.
Yeah.
Thank you. And then one other question, I guess, just to the group. For those of you that are using scleral lenses for keratoprosthesis patients, are you fitting them extended wear? And then I guess gets back to the topic of putting an antibiotic into the bowl of the contact lens, and how often would you do that?
So I'm just going to comment on Greg's question. So we have various patients that we fitted with K-Pro, and we actually have different approaches. I actually had one patient that, because of dexterity issues, he was an older patient, she couldn't do the application removal. So we trained her daughter at the time. And so she was one of the first K-Pro patients that we fitted in the clinic. And this is going back maybe around 2008, 2009. And at the time, we sort of weighed risks and benefits. She was in a contour lens. DK is about 10 or 12 or so. And she was in this lens for months at a time. And so at the time we said, okay, given the scenario, we actually fitted her so that she could wear a scleral lens with a hyperpermeable material. We made sure that we vaulted completely over the capro, just very much like when you have an in-text patient, that we're the periphery, we're not having any contact. We went really large to make sure that there was no suction over time. And the patient would wear the lens weekly in a continuous manner. And then she would remove weekly, the daughter would do that, remove and reapply. And this patient, we actually are submitting a case series for review with these outcomes with scleral lenses in capro patients. And this patient did well for close to 10 years until she finally passed, because she was an older patient. But we also have patients in our clinic that actually remove the lenses just because they can remove the lenses at the end of the day, just like a regular scleral lens patient. And with that, we haven't seen any issues with removal and complications from capro. I do have a question, but I later for the panel, but just in case somebody else want to answer, chime in the capro.
I would say our results are similar to that with our K-Pro patients. A lot of it depends on their underlying reason for the K-Pro, because these patients in many cases are going to develop a lot of mucus or issues underneath it. I don't think it's the K-Pro itself that's the issue. It's the surrounding tissue and the surrounding eye, because some of these eyes are just super funky in shape. And so you really have to watch the whole eye and just make sure you don't end up with erosions or issues with the K-Pro patients themselves. The one comment I wanted to make for the panel, though, was I really feel like everybody should give a round of applause to Dr. Gellies for his sphincter capacity on fitting that dysmetacial patient. That was impressive.
I had a question, or really a comment from Muriel in terms of decision tree and when to fit, because I feel like it's completely different for SJS patients versus GVHD patients. For us at the University of Michigan, we typically, I will see them for GVHD patients specifically. There's like a dance between when it's the right time. So I wanted to open that up to a discussion, because I feel like for us, it's usually the Schirmers is going down, and once it gets to a certain point, that's because you can't fit too soon, the patients won't appreciate it.
Right.
And then also for the SJS patients, they're smoldering, or they can be smoldering for a long period of time. So when's the right time to fit?
That is the question. I completely agree. It's challenging to know, and you want to catch them before they really go south. Here at Mayo, I am continually doing a dance with our facial reanimation team on patients who've got facial nerve 7 or cranial nerve 7 palsies who can't blink. Okay, when do we say it's okay to do a scleral lens fitting with them? Are they going to have a gold weight implanted? Are they going to have lower lid surgery? Should we try a scleral lens first in order to try to avoid some of that surgery? I agree. My threshold for graft versus host disease is pretty low. If they're using artificial tears 4 times a day and they're still symptomatic, if they're and if they've got a little bit of epitheliopathy, we'll fit them. We tend to be pretty aggressive there.
I would say for us, if there's anything there.
We need a mic.
Yeah. One more time.
Well, for SJS patients, they're going to have pain right away versus,
Yep.
so that's the question. That's like the dance that I'm talking about.
Yeah.
Right.
It's not just a dance within our clinic, though.
No.
With SJS, with GVHD, even with patients that may need gold weights or that kind of thing, it requires educating not just eye people, but people outside of the clinic. And so, I find that I'm constantly going over to the oncologist, to the other doctors, and saying, this is what I have to offer, and asking them to send the patient to me, either pre-surgical or immediately after surgery, after they're starting to feel better, so that we can start having these conversations so that it doesn't go too far, because it's hard to go back. We also published a paper last year looking at gold weights and tarsorrhaphies, and that scleral lenses actually had a better outcome,
much better.
patient acceptance.
Yes.
Yeah,
And
they are.
so that actually led us to sit down and say, don't put a gold weight in and have these
Yeah.
conversations with people. Refer them for scleral lenses first.
And I certainly appreciate that. I think that once you start mucking around with the lids and putting gold weights in the upper lid, first of all, they don't get complete corneal coverage. And secondly, it makes scleral lens fitting tougher. We also need to consider patients in this. So if you've got a 98-year-old with dexterity problems, maybe the gold weight is the thing for her, along with a partial temporary tarsorrhaphy. If you've got a very active 18-year-old after a motor vehicle accident, a scleral lens might be a really good first option there. So I think it goes back to what Karen was saying earlier, which is you just really have to pay attention to the patient too. I know I'm very excited about scleral lenses and I think everybody should wear them, but the fact of the matter is they have a higher burden of care than some of these surgical things. And if the patient doesn't mind partial tarsorrhaphy, or if the patient just really doesn't want to mess around with a scleral lens, surgery is certainly a reasonable option as well.
Okay, we have a Zoom question here from Jennifer Lau. Is there any concern of desiccation of the cornea when the scleral lens is removed in cases of K-PROSE? I assume the patient is removing the scleral lens and going to sleep. So I'm going to be honest, I don't have any experience with K-PROSE and sclerals, so I'm going to defer to the experts in the room. And can any of you guys answer for the patients that are taking the lens out with the K-Pro, what happens at night?
So the reason for the K-Pro is for protection, so that it doesn't break down, so that you don't end up having to explant the K-Pro. I mean, they universally see better without it. But the reason for the lens is for that protection. But when they just take it out at night and go to bed, they're fine, in my experience.
Some of our patients do use gels at night just for the added protection.
I would have to say overall, I'm interested in your experience too. I'm seeing fewer and fewer K-Pro. It seems to be like it's going out of favor. So the K-Pros that I'm starting to deal with now are getting really old. Like I've seen them for a decade now, and I'm seeing few new K-Pros.
I would say one of the things that we have our patients do after they've taken their lens out is to tape the eye shut. We have them use silicone kind tape, and it does a pretty good job of not irritating the lids any further. One other quick thing for Muriel though, we actually, Melissa and I had done a survey and looked at individuals who were fitting scleral contact lenses, and those those three main indications, we looked or asked them specifically, if you weren't using scleral lenses for an indication, why not? And in the OSD category, which was really interesting, one of the highest ranked reasons was for cost, which in the irregular corneal category wasn't even in the top 5. So it was really interesting. Maybe there's something inherent to our thought process on value for this and alternatives or other things like that.
So this may be off topic here, but I'm kind of removed from insurance coverage for these devices for corneal irregularity versus ocular surface disease. But if there is a disparity in that, I mean, if somebody with keratoconus can get their lenses covered and somebody with graft versus host disease cannot, I could certainly see why that would be an issue. Interesting that cost is did you ask about burden of care, or oh no, this was from the practitioner standpoint.
Yeah, practitioner standpoint.
Yeah. So patient standpoint could be a little bit of a different discussion there.
Yeah.
So I just want to ask Tom a question on your study. I think a lot of us have talked about, I'm going to take this down, have fit RK patients, and I think have experienced the spectacle blur phenomenon that patients complain about after the lens comes out. And I used to think it was related to the malleable cornea kind of having some flattening effect, because scleral lenses, even though they don't touch, have been shown to flatten the cornea. Do you think, or what do you think your experience is? Do you think that it could be swelling related?
I think it could be. One thing I want to thank, and thank you for the question, Lynette. One thing I want to point out is patients in the study, yep, hold up, there you go, are very happy with their scleral lenses. They're very, as a group, they're very happy, they're successful. They don't have the diurnal variation in vision. A scleral lens seems to be very stable for them, and they're happy. In the Houston area, we had a very active ophthalmology community. So we have a lot, Maria's nodding her head, about a third of our patients, maybe even closer to 40% of my practice, it was scleral lenses was fitting post-RK patients. A lot. No, it's true. Here's my witness right here, and right down there in the front row. But as far as spectacle blur, Lynette, that didn't come up all that much. It really didn't. You know, some of the patients said, I just can't wear spectacles because they were plus 850, minus 450 at Axis, you know, whatever. So, I can't say that it wasn't a big issue in our practice. They were uniform, not everybody, but the large percentage were very happy.
Just a quick comment about that. And, you know, the next session is optics, but I would throw it out there that maybe it's not more edema or blur. It's just a change in perception, right? Because we know that we correct so well with scleral lenses, they take it off, things got worse. Well, no, your perception has changed. So just putting that out there.
I've actually refracted the patients after a long day of wear, and they do get a different refraction than their baseline. So that's why I call it spectacle blur, but I might be off, and it could be this swelling, it could be something else. So I don't know, but I agree. There's perception, there's now edema, there's all of this.
Post-RK patients. I mean, you know, you try to, you know, in our clinic, general clinic, selling glasses, they're all over the place. You know, so.
We only have time for one more question. Louise?
Yeah, it's been a challenge, even when they were treating those patients, you know, more than 10 years ago. I think there are some local compounding pharmacies in the Boston area that could compound the bevacizumab, you know, as specified. At Mass and Year within the hospital, we have pretty easy access because we're within, you know, academic center. But literally before the talk, you know, yesterday, one of my colleagues texted me about, you know, this regimen and said that there's apparently some FDA concern about the compounded bevacizumab. And that's a recent event that she, from the military, couldn't get a hold of that to use it in the device in this way. So that surely is a challenge. I think the market is you know, we don't have a huge market for this, so there's no drive for the compounding pharmacy to provide that for us. I think one possibility of, you know, solution is to reach out to the academic centers to see if they can provide the compounded bevacizumab. My personal, nowadays, you know, if I have a patient who can be a candidate for this regimen, that's great. If not, I've done more subconjunctival injection of bevacizumab, which is much more straightforward with some good responses. But we can talk about the minor differences between treating with a, you know, PROSE device versus do a subconjunctival injection. I do think the PROSE device overall offers a safer profile for those patients than injection or topical Avastin eye drops.
One quick point that I want to put on this was that, you know, a lot of what we had talked about here were very small case studies, you know, very small groups of individuals. You know, both of those cases of mine would not have gotten published had it not been for Karen saying you need to publish those. So, these are the sorts of things that just us as a room, we should be looking at these sorts of cases and going, that this really needs to get into the literature so that we can have more information about these sorts of cases and situations.
Thank you. There's just one more comment from the Zoomers, and Greg stated that his experience with different types of lenses on archaic corneas is that no matter if it's corneal or scleral, there seems to be a shift to hyperopia after wearing. So thank you for that comment. I'd like to thank you all for your attention for this session. We are going to take it's a refreshment break now, and we'll start back up at 3 o'clock. Thank you.